Myself Rita, I'm a dietitian at Surgical Gastroenterology Medicine at PGI Lucknow. So yesterday my topic was about NAFL, NAFLD, covering NASH and all. And for prevention of NASH, lifestyle modification and dietary intervention. So today I am extending my topic till liver cirrhosis, nutrition in liver cirrhosis and assessment, nutritional requirement, and how to manage with nutrition. So outline is here: liver disease, magnitude of problems, significance of malnutrition in liver disease, altered metabolism, assessment of nutritional status, nutritional requirement and management, coping with multivitamin and mineral deficiencies, nutrition therapy. So prevalence of liver cirrhosis, protein calorie malnutrition. So I am going to talk about only nutrition, not about the prevalence of cirrhosis. So protein calorie malnutrition is highly prevalent in all form of liver diseases like NASH, NAFLD, liver cirrhosis, acute liver failure and chronic liver failure, including DCLD and all. So 65 to 100% patient comes under malnutrition stage, maybe get class 1, 2 or 3. So in different form, like decrease in skeletal muscle mass, sarcopenia, 1 to 2% of muscle mass loss every year, more than of the patient age when more than 50 years. So maybe in DCLD the symptoms or features are not so high, but muscle mass can be seen 1 to 2% every year in the patient. Cirrhosis, insufficient glycogen storage, catabolism of amino acid, breakdown of skeletal muscle mass in form of sarcopenia. Causes of liver disease, everybody knows viral markers, positive viral markers, autoimmune disorders including hepatitis, biliary cirrhosis, sclerosis, cholangitis, SLE, genetic factors, cancer, other NAFLD, NASH and alcoholic abuse. Etiology of malnutrition. Why this much of 65 to 100% malnutrition prevalent in liver cirrhosis? Because of decreased intake. When someone is diagnosed with liver cirrhosis, so anorexia, nausea, early satiety, abdominal pain due to ascites, maybe because of some very less amount of ascites is there, but early satiety is the reason because of the distended abdomen because of ascites, altered taste, unpalatable diets, restrictions are there, low sodium restricted diet is there, self-imposed diet that healthy is not allowed in liver cirrhosis or hyperbilirubinemia patient. So they restrict their diet at their own. So diet becomes very unpalatable, and that leads to low intake, constipation. That leads to secondary to gastroparesis, tense ascites, small bowel dysfunction or paralytic ileus, zinc deficiency, manganese deficiency, that actually leads because of this low intake, dietary intake, increased losses, hyperglycemia, restricted intake because of the sometimes ascites. Cirrhotic patients are with diabetes are insulin resistant, so they themselves restrict their diet in carbohydrates, they restrict their diet in fat intake because of hyperglycemia or because of their diabetes. So malabsorption of fat and fat soluble vitamins is very common and very prevalent. Intestinal losses of protein, low protein synthesis and altered metabolism and increased expenditure of energy intake because of the cirrhosis. Your cirrhotic stage, that body goes into hypercatabolic stage, glucogen storage is reduced and the body demands more of energy for the catabolic responses to respond to the infections and this ascites. Protein synthesis decreased liver, that in the cirrhosis condition protein synthesis is very low, and so as serum albumin is low, increased fat metabolism, glyconeogenesis is active. Altered metabolism. Liver is a factory which is responsible actually for carbohydrate, protein, fat metabolism. So carbohydrate metabolism is directly, indirectly regulated by the liver hormones, which are glucagon, glycogen storage, cortisol, directly, not directly, but indirectly, cortisone, glycogen storage, and cortisone is adenocortisone is also responsible for the carbohydrate metabolism. Protein metabolism, low or no protein synthesis, restriction of anabolic hormones, lower branch chain amino acid to ratio. The dietary restriction is the dietary restriction or low palatability or low dietary intake leads to less amount of protein intake, so as branch chain amino acid and amino acid ratios goes down in the diet. Fat, preferred fat is always preferred by the preferred source of energy by the body. So here fat is restriction, self-imposed diet is because of self-imposed diet, fat is restricted, and so as high nocturnal fat metabolism that impaired synthesis of PUFA and MUFA. Patient they themselves restrict the fat intake, like tala bhuna nahi lena hai, even they restrict the daily amount of which is really recommended or which is really required by the body, but they restrict their dietary intake in form of fat. So how to assess the nutritional status once the patient come to the OPD or IPD? So what are the method by that can be patient assessed? Patient can be assessed for the nutritional status. So here are 4-5 method, basic method in my someone's setup, which really is important to know how to assess the nutritional status. That is in form of A, B, and C and D. A is anthropometric, B is biochemical, C is clinical, and D is dietary method. So here SGA is the basic and more very important method to assess this nutritional status in cirrhosis patient. Weight loss more than 5% comes in mild category. Moderate category 5 to 10.5. So here I missed this decimal point. So if the weight loss is more than 5 to 10% of the total ideal body weight, patient comes in moderately nutritionally deficient patient. Severe, more than, if the weight loss is more than 10% of the total ideal body weight, food intake need to be assessed, maybe by dietary recall, maybe by weighment method, maybe by questionnaire method. So this is the and this comes under SGA, evidence of malabsorption in form of iron absorption, iron intake, anemia, steroidea, weight loss, inches loss. Evidence of specific deficiencies with there can be questions like what kind of serum parameters are available in institute in the setup, which need to be assessed in form of vitamins and minerals deficiencies. Functional status that can lead to the mobility or sarcopenia status, that can lead or that can show the status of the functionality of the patient. Physical examination, anthropometric measurements. So body mass and anthropometric measurement is the basic and most easy method by which body mass index need to be assessed. Weight in kgs upon height in meters square. So this is the BMI range where WHO has WHO has categorized into, in general population all over world, the BMI cutoff is different, and in Asian context the BMI cutoff is different. Earlier in Asian context the BMI range was 18 to 24, almost in 19 to 24, 23.9. But on this cutoff, higher cutoff, the prevalence of metabolic diseases like NAFLD, NAS has been seen more, with insulin resistance, diabetes, and stroke and cardiovascular disease. So WHO had decided to reduce the cutoff the BMI. So now the normal reference range of BMI is 18.5 to 22.9 for the Asian Indians, and the normal range is now 20 2.9. So here the prevalence of diseases including NASH and NAFL is less. So as the prevalence can be less because of NASH or NAFLD. Anthropometric measurements: whole body fat, triceps, subscapular skin fold thickness by Herpendon caliper. Skeletal muscle mass can be measured by the Herpendon caliper. Mid-arc circumference can be easily measured by the simple inchy tape. So these are the easy method that can be used for the nutritional assessment of the patient, which is basic and very easy to perform in any setup. Biochemical parameters, which actually denotes the nutritional indicators or nutritional markers: serum proteins in form of albumin, serum transferrin, retinol binding protein, creatinine height index, hemoglobin, B12 deficiency, folate and vitamin deficiency can be assessed or can be advised to patient for assessing the biochemical parameter, which is actually indicator of the nutritional deficiencies. Again, no single parameter is sufficient or sensitive or specific the assessment. So better to assess A, B, C, all the parameter, whatever is easy and whatever is accurate and precise in the setup. So A is this anthropometric, B is biochemical, C is clinical, and D is dietary method. Nutrition requirement and management. Energy. So protein gives, everybody knows that 1 gram protein gives 4 kilocalories per gram, and carbohydrate 4 kilocalories. Fat depends on the quality of fat. If it is this MCT or long chain triglyceride, MCT or LCT, so it depends on the quality of fat. This gives 8.6 to 9 kilocalorie per gram. Even during exercises, glucagon and triglyceride in muscle provide energy by glyconeogenesis. Energy requirement: how to estimate once the patient is assessed in the setup, once the patient comes to the OPD or IPD for treatment. Nutritional assessment need to be the first, along with the treatment. It should be the nutritional assessment should be given the priority to assess and then decide the energy and protein requirement. So here, energy requirement assess. How to assess? Total energy expenditure. This is the basic, how much energy one expend in the lying down position or in the basal form. So this is the basic and most relevant formula of Harris-Benedict equation. This here you can see the Harris-Benedict equation is different for men and women. By using this equation, one can decide the total calorie expenditure in basal condition or in resting condition. So resting condition, the total energy is in resting condition, whatever is the recommended, 60 to 75% energy is consumed in only resting condition or in basal condition. Rest 10% is used for thermic effect of food. And energy expenditure in physical activities 20 or more than depends on the type of activity. It's a sedentary activity, it's an intense activity, what kind of physical activity has been performed. The energy expenditure or energy utilization depends on that. Stress factor. The disease or catabolic stage depends on the type of disease or the catabolic stage or infection rate of infection. So how to total and estimation of energy depend is here. Total energy expenditure is equal to resting energy expenditure plus activity factor. Activity again that I elaborated here, the type of activity depends. So PAL is physical activity factor plus total energy expenditure in food plus stress factor. Energy metabolism. So energy metabolism is here. Again the same second factor is here that makes the understanding easier how to calculate the energy expenditure, how to calculate the total energy intake in the patient. Here you can see the total activity factor. It depends on the activity factor, depends on the type of activity, and examples are here. Injury and illness, hypercatabolic activity factor plus illness or stress factor. So injury or illness. So depends on a type of injury. It is burn. Again, burn bodies. BSA is body surface area. How much percentage of body surface area is involved for the burn? So it depends on body surface area. Again, in severe infection, acute pancreatitis, bone fractures, and different type of sepsis, and it depends on the basically the stress factor. Energy intake in hospitalized patients. So here is the simple and alternative formula based on the BMI given by the WHO. So if the patient is underweight, so calorie calculation can be as per ideal body weight for the height. So patient is underweight, 35 to 40 kilocalorie per kg of ideal body weight. If the patient is normal, comes under 18.5 to 22.9 BMI, 30 to 35 kilocalorie per kg of ideal body weight, obesity grade 1, 2, 3. So accordingly, you can see the calorie calculation is, energy calculation is here, plus need to be, again after calculation of the resting energy expenditure, need to consider the physical activity, stress factor, and then the total calorie can be estimated. Protein. So here in EASL guidelines, according to EASL guidelines, protein requirement in chronic liver disease, DCLD, or in liver failure, even in chronic condition, protein requirement is 1.2 to 1.5, can be increased up to 2 gram. In ACLF, with or without this hepatic encephalopathy, up to 2 gram can be considered. It depends on the patient tolerance. Avoid protein restriction in patient with HE grade 1, A grade 2, and grade up to 2 grade 2. In HE there is no need to restriction of the protein. Transiently 0.4 to 5. Actually, this has been noted here. If the patient has slow bowel movement or paralytic ileus, so there is the chances of aspiration, and protein gives this gastric emptying delay, makes the gastric emptying delay. So chances of aspiration is more, and protein takes a lot of time to digest. So transiently 0.5 to 0.8 kilogram per kg per day can be encouraged up to the patient the paralytic ileus comes to the normal stage only. Otherwise, there is no need to restrict the protein even in grade 1, 2, 3 HE. Amino acid. So the diet should consider all the vegetable protein basically in the acute phase. So these are the amino acid which need to be considered in diet while planning for protein. BCCA, branch chain amino acid, this is basically that helps, and that is much recommended in cirrhosis and basically in ACLF condition. Leucine, sources of leucine are cheese, soybean, beef, chicken, nuts, seafoods, and fish beans. This leucine content basically comes from the animal protein. So here in ACLF condition where paralytic ileus and paralytic bowel is involved, and the chances of aspiration if patient is on ventilator or in more of on ventilatory support, their protein need to be just for the time, just for the some hours till the patient chances of aspiration reduces. So otherwise, this high biological value protein that comes from the cheese, soybean, beef, chicken, eggs, beans, fish need to be considered. Isolation comes from egg, soy protein, chick, cheese, fish. Well, in mushroom, whole grains, bean, fish, nuts, seeds, chicken, soybean, beef again. So this is the high biological value protein which is containing the more of branch chain amino acid. So need to be considered while planning for the protein. Need not to be every time you need not to be restrict the protein even in HE. Carbohydrate. So basic source of, major source of energy for the cirrhosis patient is carbohydrate. Contains starch, sucrose, lactose, generate monosaccharide, glucose, fructose, galactose. That is the major source of energy for cirrhosis patient, and that empties the gastric region early, so that feed or food can be given early for maintaining the gap and for covering the total protein and this carbohydrate intake. 50 to 60% of the total calories should be from simple to complex carbohydrate. Actually, complex type of carbohydrate need to be minimized during this acute phase, so that gastric emptying need to be ensured early, and more of the feed and food can be allowed to the patient, and total calorie and protein can be achieved. Alteration in metabolism. So in cirrhosis patient, reduced glucose tolerance, insulin resistance, early diabetes mellitus is observed. So carbohydrate, while planning this carbohydrate, these points need to be considered, and if there is intolerance, insulin resistance or type 2, already patient is diagnosed with this type 2 diabetes, so wisely choose the type of carbohydrate and accordingly plan. Carbohydrate metabolism. Why carbohydrate metabolism? Earlier I was saying that carbohydrate is the major source of energy for cirrhosis patient, because it allows the gastric emptying early, so as next feed and next food can be given early to achieve the total energy intake. But here again, the carbohydrate metabolism is altered, and next step comes to this insulin resistance and type 2 diabetes with type 2 diabetes patient. So carbohydrate metabolism is important because of stimulate insulin secretion and anabolic process, reduce the anabolic process, inhibit muscle protein breakdown, stimulate muscle protein synthesis. This, if the carbohydrate intake is proper, that decreases endogenous glucose production from amino acid. So that amino acid or protein can be spared for the muscle mass and protein building for this other protein like serum transferrin can be achieved. This normal level of serum transferrin can be achieved, and albumin can be maintained. Fat. Total, more than 30% of the total calories can be fat from the fat. Again, it depends on the patient condition, case to case. If the patient is tolerating well, 30% of the total calories can be from fat, and most of that up to 70% of the total calorie from the fat should be from MCT. The sources of MCT are the cheap source is coconut oil. Better to use coconut oil for better absorption. Essential fatty acid, linoleic acid, flaxseed, soybean, canola, walnut, sunflower need to be added. Corn flour, sesame oil. If the availability of this different type of this oil is there, so by changing the type of oil can be used for achieving this linoleic and linoleic acid for better absorption of the fat. Fat should not be restricted. As I said, that there is a self-imposed kind of diet in cirrhosis patient. The patient comes with the jaundice, or the patient comes with the hyperbilirubinemia, and they said, I'm not taking fat, or I'm restricting the fat because the liver is the responsible organ which metabolizes the fat, and they restrict the fat, or they are almost nil in taking the fat. So here fat is not need to be restricted. Total calorie from fat should not be less than 20 to 30%. Consists linoleic acid and linoleic acid, omega-3 and 6. Omega-3 and 6 are responsible for acts as anti-inflammatory factor. So more of fat should be from this linoleic and linoleic fatty acid, and omega-3 and 6 requires high PUFA and MUFA ratio. So from where, what are the main sources of the MUFA? Olive oil, nuts, almonds, canola oil, avocado, nuts, butter, olives, peanuts, etc. PUFA. corn oil, soya oil, vegetable oil, walnut, and peanuts oils, flax seeds are the major sources of this PUFA and MUFA. So need to be added in the diet of the cirrhosis patient, basically in ACLF condition, that provides the factor of this anti-inflammatory factor in form of this omega-3 and 6. Major minerals need to be, while planning diet for the cirrhosis patient, major minerals need to be considered at per RDA to prevent this, to prevent weakness, hyponatremia, weakness, paralysis, arrhythmia, weakness, itching, tetany. These are the symptoms, sign and symptoms, clinical features, weakness, fatigue, which leads because of the deficiency of the phosphorus, magnesium, potassium, and sodium. So these points and these minerals need to be considered highly while planning a diet for the cirrhosis patient. Micronutrient deficiency and sources. Micronutrient deficiency in liver cirrhosis, up to 10 to 50% of the patients are found to be deficient in microdeficiencies. Vitamin A deficiency is very prevalent in cirrhosis patient. That leads to accelerate degradation of and maintain the integrity of the tissue and cells for this biochemical processes like catabolism and anabolism. Water soluble vitamins. What are the sources that can fulfill the requirement of the vitamin A, which is called as thiamine? So here you can see the majorly this comes from the animal protein, milk and this animal protein and fish, nuts, and some of wheat grains. It comes from basically animal protein. It comes from the animal sources. In deficiency of thiamine leads to Wernicke's hepatic encephalopathy. This is also called as minimal hepatic encephalopathy. So minimal hepatic encephalopathy can be prevented if the thiamine infusion in acute phase. Thiamine infusion is also recommended, but I am not going into that. So better to encourage and enhance the dietary intake of the thiamine in form of milk, meat, fish, nuts, and all. Vitamin B, paradoxine leads to, again, paradoxine parallelly is responsible for the Wernicke's HE, minimal hepatic encephalopathy. So what are the sources of paradoxine? Basically, it comes from sources of vegetable, banana, kale, papaya, and nuts, ragi, and this barley. 9, folate. So here you can see that major B complex group is responsible for many deficiencies and leads to life-threatening conditions. So focus on the vitamin B complex like B1, B12, B6, B9. So folic acid is also responsible for the pernicious anemia and normal anemia because of the cyanocobalamin and this folate deficiency. So here you can see the major sources of the folate. So basically it comes from the vegetarian sources: orange juice, beans, spinach, raw rice or bread, fortified bread, and this pasta, oats. And again, if in acute phase, the supplementation can be given. Micronutrient deficiency, these are the RDA, and this is the recommendation, and between the gap, when in acute phase, this recommended dietary allowances in acute phase goes up to this much. So better to encourage the patient to take the balanced diet, and in condition encourage some of the nutrient and ingredients need to be added and enhanced in diet. So vitamin D deficiency, again vitamin D and calcium serum deficiency is more prevalent in the cirrhosis patient. So need to be taken care of this vitamin D and calcium sources in diet. Nutrient energy composition of hospital feed and at our institute. So you can see in general we provide in my institute, we do provide this kind of feed that provides hepatic feed, During the acute phase of this hepatic encephalopathy in grade 3 or 4, we do provide 1000 kilocalorie feed in at a time. That provides almost 14 gram protein, and total volume is this much, 730 ml. It depends on the patient tolerance, maybe 100 ml 2 hourly, maybe 200 ml 3 hourly, or maybe 300 ml 4 hourly. It depends on. So these are the major type of feeds which provide this much of protein, and this much of volume is here mentioned here. Nutrition therapy. Minimal nutritional deficiencies need to be covered and need to be carefully observed and evaluated, so that the patient does not go into the malnutrition state if he or she goes into that, but need to be taken care so that can be covered early. Summary of the dietary intervention. So again, whatever I said that need to be evaluated for nutritional assessment, need to be covered for deficiencies, and need to be covered for protein, calorie malnutrition. And summary: protein, energy malnutrition common in liver cirrhosis disease, and mechanism other than low intake contributes in deficiencies, so need to be taken care of. Dietary intake, limitations of various techniques in nutritional assessment. So whatever technique is possible in the setup, in the institute, organization, just do that level of nutritional status, so that patient may not fall or may not threatened by the nutritional condition, poor nutritional condition. Protein restriction only in acute encephalopathy. Again, I would add on protein restriction if paralytic ileus or bowel movement is not enough, then only restriction is recommended. Otherwise, 1.5 to 1.8 or 2 gram protein per kg of body weight can be, if patient is tolerating, can be recommended. Oral branch-chain amino acid supplement when not tolerating sufficient dietary protein. Yes. Role of micronutrient and antioxidant very important in CLD. So more of colors and variety of food and vegetable need to be included in the diet to enhance the antioxidant and anti-inflammatory factors like omega-3 and 6 can be achieved. Conclusion. Nutrition in chronic liver disease are rapidly evolving field and the object of growing clinical interest. So I would request, and this topic is really close to my heart, so I would say that whenever the patient comes to OPD or IPD, if you are dietitian, clinician, hepatologist or gastroenterologist, just along with your treatment, just patient need to be encouraged for the nutritional assessment, so that the outcome can be improved up for better prognosis and early recovery. Undernutrition and sarcopenia are also interconnected with other complications of the cirrhosis such as hepatic encephalopathy, ascites, and other susceptibility of infection and sepsis. So nutrition, if patient is under nutrition, again the prognosis is poor, again the outcome is poor, hospital stay is going to be lengthy, so need to be look after for the nutrition, and intervention need to be early. Anyway, thank you so very much for patiently listening. Any question, please?